Hi, everybody. We're going to talk initially about an overview of the new and developing technologies for diabetes management, especially those that involve connection, Internet of Things, and artificial intelligence. So, this is going to be a very brief summary, but we hope it will be useful for you. So, first of all, we have to talk about the size of the problem of diabetes in global numbers. By the year 2000, it was estimated that about 171 million people in the world live with diabetes. By the year 2010, the number had already increased to 285, and if no action is taken, what we expect for the year 2030 is to get to 366 million people with diabetes. So, as you can tell, the problem is increasing in size, and there's no signs of it abating over the next few years. So, definitely, we need to get prepared to do a better job taking care of these patients. Now, where in the world are most patients with diabetes? It's not equally distributed. It is concentrated in some geographical areas. And I want to highlight that the rate of growth of diabetes prevalence is particularly high in Latin America and the Caribbean. So, if you compare the year 2000 with 2030, it is expected more than a doubling of prevalence. It is a huge increase, only comparable to what's happening in Southeast Asia. So definitely we need to have locally developed solutions to prevent diabetes and to take a better care of patients already diagnosed with diabetes. Actually, the role of diabetes as a direct cause of death is also increasing. By the year 2007, type 2 diabetes was the direct cause of death number 14 over the world. And by 2017, it had already risen to position 10. Now we have to take into account that diabetes is also a risk factor for many other things that can also kill you, like coronary disease or stroke or many other conditions. But in and of itself, it is already responsible for, it's in number 10 among the direct causes of death. So it is increasing, it is deadly, it is widespread, and it is increasing particularly fast here in Latin America. And a very worrisome trend is that the countries most strongly affected by this progression of diabetes are mostly low and middle income or developing countries. So by the year 2030, it was expected that only one out of the top 10 countries in terms of diabetes is a developed country, and that is the United States of America, in terms of number of patients with diabetes living in the country. All of the rest, you can tell, are low and middle income developing countries. So, definite, we need to do something to direct efforts to this sort of environment, not just to developed countries. Now, we have some very recent data from Colombia, particularly from urban Colombia. So we have submitted this paper. It's the prevalence of urban diabetes in Colombia among adults. And the first thing I want to highlight is that in this age bracket between 60 and 80 years of age, the prevalence of diabetes in both men and women is more than 30%. So it's extremely high. And you know that the population is aging not just here in Latin America, but all over the world. So this situation is actually going to get worse with almost absolute certainty over the next few years. So as population ages, this is going to increase. And a second layer of complication for this is that it affects mostly people with low education and or low income, people who are socially disadvantaged. And this is the correlation between the highest educational level attained and the prevalence of diabetes. You can see, particularly for women, women who only completed elementary or lower education have much higher prevalence of diabetes overall than those who have secondary or university education. So we need to do a better job in educating people and focusing efforts on people who are excluded from educational opportunities. This is the same trend, but with socioeconomic status. Again, the trend is evident for both men and women, but is most pronounced for women. Now, with that very brief intro about the size of the problem and the current situation of diabetes in Colombia and the world, I would like to introduce you to what we call the big four technological advances for diabetes. So there are many more, of course, but these are like big four areas that we're going to be discussing today. One of them is continuous glucose monitoring, or CGM. So this is a group of devices that try to measure glucose, interstitial glucose, in an almost real time fashion. It is not completely real time, but it's an approximation to having a continuous record of how your glycemic levels are evolving. A second group of technologies involves the automated insulin delivery. So this is what usually people call colloquially insulin pumps. So it's microinfusion devices, and then the most recent versions of them incorporate some sort of artificial intelligence solution to try to couple information derived from either glucose levels from CGM or patient-derived inputs like food and exercise and time of the day, and try to integrate that using algorithms to fine-tune the rate of infusion of glucose, or to give or suggest boluses for fast to replace fast insulins. A third group of technologies is that of smart insulin pens. So this one is less expensive as AID devices, so it is sort of a cheaper replacement for that. It doesn't do everything that an AID device would do, but it can suggest boluses, it can remember your last dose, it can remember the time, and you can also input other information to the pen itself. Some of them are the complete pen, and some of them are a cap that you can put on top of a pen, a regular insulin pen, and it will detect the dose and it will remember it and it will record other information and store it for later use. It may also connect wirelessly to other devices and to your computer or your cell phone, and work with diabetes management applications. And that is the fourth big group of technologies, and that is digital health apps. So applications developed to try to improve and or aid the patient in the management, the overall management of their condition. Some of them are more focused on one aspect, say nutrition or some in physical activity. Some are more towards insulin and everything associated with it. But I think the real advancement we're seeing is in those that try to integrate all these inputs into a single one-stop shop for management of diabetes that may empower the patient to take control of his or her disease. So these are the four areas we're going to be discussing. Particularly, we're going to focus a little more on CGM. So the first question is, why CGM? Do we really need to be measuring glucose all the time? Does that provide any advantage? And yes, it does. And this is sort of a hypothetical example of why that would be. So let's say we have a patient with this kind of glycemic levels over the day. This is a 24-hour period. Uh, and then if we average the measurements of these patients, we will find that they are on average 130 milligrams per deciliter, which corresponds roughly to an A1C of 6.3%. So this person is most of the time within the established limits, within the range. And then the average is good, and the A1C is in gold, is good. But let's think then about this second patient. So this is the pattern. There are very wide postprandial excursions. There are several hypoglycemia episodes, and it's just generally irregular, fluctuating, and kind of unpredictable. Now, if we take the average measurement for this patient, it would be exactly 130, and the predicted A1C would also be 6.3. So this patient below does not have the same cardiovascular risk, metabolic risk, hypoglycemia risk as the one on top. So definitely there's a lot of information that is kind of buried, that is behind, or that we cannot reveal using just the average measurement and the A1C. And for that, we require the continuous or almost continuous trace of glucose in the interstitium. So the central idea of CGM is then to have some kind of electrode that can be placed in the interstitial fluid, and that by reacting with glucose molecules will generate products with the ability to generate an electrical current. And there are many chemistries for this. This is the glucose oxidase chemistry, which is the most extensively used, but there are others. And then different sensor molecules are able to translate the detection of those subproducts into the generation of an electrical current. And of course, the most important thing is that over a broad range of glucose concentrations, there is a proportionality between glucose concentration and the intensity of the electricity that's generated. And then this is what is transmitted to the electronics in the device. So if we want to talk a little about the characteristics of CGM sensors, they generate an almost continuous trace of interstitial glucose. Why almost? Because it's only every 1 to 5 minutes. It depends on the technology. But then that's pretty good. They of course reduce the need for capillary measurements because you don't have to be finger pricking all the time. They provide additional information on fluctuations and trends, so you can get summary measures, which we will be discussing, like the percent CV and the timing range and so on. And they also reveal hypo and hyperglycemias that otherwise would remain buried with only capillary glucose and A1C. Um, Now, there is a very important measure of the reliability and the precision and the accuracy of CGM devices, and that's the MART. And you always see next to every new model, next to every new technology, the MART that is reported. So it's mean absolute relative difference. It sounds a little counterintuitive to have something that's absolute and relative. But what it really means is that you calibrate your device against a reference method, which is usually a yellow spring analyzer for blood glucose, and then you report the mean difference of the measurements against the average reported by the gold standard. So it's how much do you deviate on average from the average of the standard. And that's what we call the MART. Of course, the lower the better. And what you can see here is the evolution over time of the MART of CGM devices over the, say, the last 20 years. So we started between 13 and 14, and it has continually gone down. We want less than 10 as a general rule, and many devices are now below that threshold, um, which represent a pretty useful and clinically relevant accuracy. Now, on top of that, some CGM devices are able to be connected wirelessly to other objects or to, say, cell phones. So I want to summarize here the characteristics of connected CGM devices. This is not an exhaustive list, but these are just a few of them, maybe the ones that are most popular or more widely used. Um, the freestyle line, Dexcom, and the Medtronic Guardian. This is the diameter. It is usually very small, between 2 and 6 centimeters. They're also very discreet, very easy to wear, very easy to install, very easy to peel off. The duration of the sensors are between 7 and 14 days. So this is how often do you have to replace the sensor. The range. So if, say, the detection device, either my cell phone or the receiver of the device, how far can it be so that it will still take the signal of the measurement from the sensor that's on top of my skin? So it's between 6 and 10 meters, which is pretty good. This is the warm-up time. So after I install the sensor, how long will it take to get my first measurement? And that is usually between 60 and 120 minutes. So we are trying to get this down, or new technologies promise to shorten this time, but there's usually some warm-up time. And then for how long can the device itself store, or the sensor itself store the data before it has to be transmitted or downloaded somewhere else? So this is the general overview of them. So they're generally small, discrete, they last several days, they have a good range, they have similar warm-up time, and then there are differences in the ability to store information for more or less time. Now, what kind of data can we get from a CGM device? Or this is a standardized CGM report. You can get the number of days the sensor was used. That's really important. And the goal is to have the whole sensor use all of its life, useful life. The glycemic average, which is really not important, and I hope I have been able to convey that message. The average in and of itself is pretty useless. The GMI, which is an estimated HbA1c, so according to sort of the area under the curve of the whole trace. Number four is glycemic variability, so the percent coefficient variation in your measurements, and the goal is to have less than 36%. The time above range, so how for what percentage of the time were you above 250, and the goal is to be in that level less than 5%. Time above range of 180 to 250, and you should be there less than 25%. Time in range, which is the primary measurement we're interested in, is you should be in this range between 70 and 180 more than 70% of the time. The time below range between 54 and 70, you should be there less than 50%. and then below 54 you should be less than 1% of the time. And you can see all of that data summarized in a very nice single color coded figure like this. So it is very, very nice that all the reports have been standardized into this shape, which is pretty intuitive and very useful. So let's move on to AIDs. So insulin pumps. So these are automated insulin delivery systems. They're extremely useful. They have seen major advances over the last few years. They tend to be very expensive, especially for type 1 diabetic patients. Um, in some countries, all of them. In most countries, a few of them, like say in Colombia, they are reserved for patients with hypoglycemia unawareness and or very labile, very difficult to control type 1 diabetes, and a few with type 2 diabetes. So these kind of devices infuse insulin subcutaneously based on a sophisticated algorithm that continuously adjusts insulin delivery in response to several factors, like the CGM glucose levels. So they try to use inputs from the CGM that connect wirelessly to a CGM that the patient is wearing, and use the data to fine-tune the insulin infusion rate. They also use data on the residual insulin action. So this is why involves some really heavy mathematical calculations, because you have to think about not just what the glycemic level is now and how much insulin you're going to infuse, but how much is left from the last infusion, either bolus or basal. And then you have to integrate that to adjust what you're going to do next, and you have to do that in a real-time basis. So it's really complex. And then you can also input information by the patient, like meal intake, exercise announcement, and other factors. Now, a very interesting feature of some of them is that they allow total or partial mobile control, so you can operate them from your cell phone. Say the Medtronic 780G, which is this device, it has a smartphone app that you can use as a secondary display. So the device itself has a display, and then you can use your cell phone as a secondary display. And you can share insulin and glucose data using a dedicated app. The Tandem Slim, which is this device, it has also its own screen, but you can it can use your smartphone to suggest bolusing or to infuse yourself with boluses. And insulin data can be shared via mobile app as well. The Omnipod 5, which is a pod and a pump in and of itself. So it's really, really neat and has a very high acceptance and preference by patients. It has full smartphone control, so you can totally operate it from your smartphone. It does not have a dedicated or a standalone screen. And it has a proprietary app called Gluco that you can use to register and check all of your data coming from the CGM and the pump. And then this is just one model of the many closed loop devices actually in development. So these are devices that use the data from the CGM plus historic data plus any other inputs and then adjust by themselves the insulin infusion rate. So you don't need to have patient intervention. You can sort of let it operate on its own. It's what many people call an artificial pancreas or a bionic pancreas. Many people do not agree with that nomenclature, but in any case, that's what it does. It has a mobile app as a companion app. It has to be operated using the screen. And it provides real time glucose data that can be shared via a Dexcom follow up. So you can see many of them are connected. Many of them are offer different functionalities that make things easier for patients. But again, the accessibility to this kind of devices is not really widespread because of their cost. Now let us move on to smart pens. So these are sort of a lower budget solution that tries to provide some of the functionalities of AAD devices. So the first insulin pen, just a regular insulin pen, appeared in 1985. By 2007, we had the first, quote, smart pens, which were able to basically store the last dose and remember them for a while, date time, and the size of the last insulin dose. And from 2010 to today, new features have been appearing like built-in dosage calculators, like connectivity with CGM devices, and like connectivity with smartphone apps. So They're moving more and more in the direction of a connected AID device. So this is just a regular pen. It was a big advancement from syringes and vials. It's a major step. And then in 2007, we had the first. You can see this little screen here where you can call the last dose that you gave yourself, just in case. But then there's been major progress in this, and now we have caps that function as pens, as smart pens. We have smart standalone smart pens. We have associated um, mobile phone apps. So there's a plethora of these products, and they only get better every time. So some examples are the Abbott Diabetes Care Unity. This guy, this is really a cap that you could place on top of a regular insulin pen. The NovoPen Eco Plus, which is this pen. The Medtronic InPen, which you can see here, with the associated CGM sensor. And the Eli Lilly Tempo, which you can purchase as the pen itself or as a cap that offers some extra connectivity functionalities. And then we move on to the fourth and last big area of digital innovation and electronic innovation in diabetes, and that's digital health apps. So one interesting piece of data is the following. So the projected world population by 2029 is 8.5 billion people. So we will have 8.5 billion people in the planet. And by that time, the projected number of smartphone users is 6.4 billion people. So we are getting to the point where we will have same number of cell phones as people in the planet. It's really absolutely breathtaking. The rate of growth. These devices did not exist like 15 or 20 years ago, and now they have completely taken over the world, taking over our time and attention as well. So, but you can use them to try to improve diabetes care. So digital health apps, if you look up for them in the field of diabetes, you will find at least more than 2,000 diabetes related apps in one or another way, but very few one-stop shop solutions. So the uses of digital apps for diabetes include CGM, the checking on your CGM data or taking action based on that, stress management, and more apps offer that kind of service. Healthy nutrition, either just as information or coaching, and in some cases you can input actual data. Virtual coaching on general aspects of the disease. Weight monitoring, so you can check your weight history and how it's been changing um, with different interventions. Some of them include blood pressure or EKG monitoring, trends in lab values, so your lab history, physical activity tracking, which is really crucial in the management of diabetes, and or AID information, the rate of infusion, the last boluses, the timing of the boluses, and so on. So as you can see, there are many aspects to consider that can or that you may consider incorporate into a digital health app. And some of them may be more important to some subgroup of patients, but definitely all of them have a role to play in diabetes management. And this is a really interesting systematic review and meta-analysis of the effectiveness in real-world conditions of this kind of digital health apps. So, in this research, the authors tried to conclude or to investigate how big was the size of the modification in an objective outcome, that is A1C, from using or not this kind of technology. And this is just a brief summary, but in type 1 diabetes, the estimated A1C reduction was 0.46 points, which is not huge, but is clinically relevant. And for type 2s, the reduction was actually minus 0.90. So it was much larger, the effect in type 2. So definitely they work, they provide an advantage, and they really modify objective measures of metabolic control, like, say, glycated hemoglobin. So with that overview, we can now move on to more specific info about the current trends in AI and the Internet of Things in diabetes. I want to thank you for your attention, and now we move on to Dr. Bocolo.
Okay, thank you very much for the opportunity. I am Anthony Bocolo. I work as a senior researcher in Department of Applied Science, IFE, Norway. So for today, I'm going to give a a lecture on the current and future use of AI for the prevention or management of diabetes. So I must say this is a project where we receive a brief funding from the Research Council of Norway. So this is under the thematic area of democracy and global development for global health. So the agenda of this presentation is clustered into five main core areas. So I start with the introduction and contextual information, and then I proceed with the background and overview. And then we have the current application and use of artificial intelligence, which is AI. And then lastly, the recommendation with some discussion on the barriers, and lastly, the conclusion. So as I was saying from the slide, currently the number of type 2 diabetes and type 1 diabetes is currently high across the world. From the presentation, you can see that 1 in 10 adults are faced with this epidemic. So there is need for research in this area. And also this finding from the IDF, which is the International Diabetes Federation, also show that mostly 1 to in 18 adults from the age of 20 to 79 are also having impaired fasting glucose. And this is carried out to help reduce the glucose blood content. And then if you go to low and medium income countries, so 3 in 4 people are also faced with diabetes, and 1 in 2 adults are actually undiagnosed. So there is also a lot of cost that is being spent in addressing diabetes management. And you can see that over the years, there have been almost 6.7 million deaths attributed to diabetes. So this shows the need for research in diabetes self-management and how this epidemic can be well managed, mostly from the citizen or the patient or from the people's side. So this information also showed that there have been an increment of number of people with diabetes. This is in million from the year 2000, and this is lastly reported from 2021. So you can see the increments, and also it is projected that as the years go by, that there will be more increments as shown in this prediction. So what is actually diabetes? So diabetes is actually a metabolic disorder characterized by the elevated levels of blood glucose, which over time, if not well addressed, can lead to complications and can lead to issues such as significant morbidity and mortality for patients. So mortality is death, and then morbidity is people living with this disease. So there is need to explore how digital technologies such as AI can be implemented or used as a facilitator to manage type 2 diabetes. So AI is actually one of the fast growing disruptive technologies around the world, as you can see with ChatGPT. So AI is already being used for diabetes management. It has been used for diagnosis, and it's also used for management of diabetes condition. And the findings from 2017 actually showed that 61% of practitioners in the healthcare sector actually feel that AI is useful, and they consider it as a transformative technology. And this is also going to shape and is also already shaping the digital health sector. So definitely, it's evident that AI has made significant progress in transforming the available data and clinical information into valuable knowledge. So AI has been used to analyze existing data sets for patients, and this has been used to provide clinical decision support on how to provide preventive and managerial advice for patients on how they can address diabetes. So for the definition of AI is being seen from different perspectives. So we have AI from practitioners from psychology. So there is a need for us to have a predefined definition of AI. How do we see AI when it comes to healthcare, and mostly in this diabetes management. So AI is actually in the field of this study or in our research area, we classify AI as a multidisciplinary field, and we see it from the computer science, and it deals with the creation of systems. So a system can be like an application, it can be like a software, it can also be the creation of algorithms or model like LLM, large language models, and these systems are capable of simulating or imitating human intelligence. So this is how we see AI, definition of AI, and findings also from the literature suggest that AI shows potential for providing real-time structured and unstructured health data available for care of patients with diabetes. So this is one of the findings from the literature that AI has been able to help to address real-time structured and unstructured data. So structured and unstructured. Using this data set, AI has been able to support patients with type 2 diabetes for self-management of their illness. And AI can also help to automate tasks. For example, it can help to provide intelligent behavioral management. It can help for learning. It can help for adaptation for patients or people with type 2 diabetes to adapt their regimen or adapt the intervention. And thus, this has helped to provide solution to address real life problems such as diabetes management. So evidently, AI has introduced a paradigm shift when it comes to diabetes care as compared to the conventional or the traditional initiatives that have been used, since AI provides data-driven precision care, so care that is being personalized for the patient based on the data that they collect from these patients. So this shows that AI is actually one of the emerging technologies that is transforming diabetes self-management in the society today. And as we can see from the slide, AI has been used for diabetes management already by different practitioners, mostly in four main areas. So it has been used to improve screening and detection of diabetes, retinopathy, and macular edema. So this is for patients that have retinal um, disorder. So AI has been used to provide treatment for this and also to detect and to recommend treatment. And AI also has been used for predictive risk stratification and treatment. So it has been used to predict risk. Stratification is for a particular population or for a particular set of people. So AI has been used to predict and to provide treatment, and AI has been used for decision support to develop decision support tools for clinicians to provide support for them on how they can improve treatment. And lastly, AI has been used for patient self-management aids. So for our current research, we are more concerned about this fourth part on how AI can be used for self-management, mostly from the patient side, based on the patient-centered treatment, how patients can actually provide treatment for themselves using artificial intelligence. So in the current literature, there are so many other areas where AI has been used and is still being investigated. So one of them is for diabetes management and for treatment, where AI is used to manage insulin dosage. And AI is also used for diagnostics and for imaging technologies to do image classification, to identify patterns that can help to provide recommendation. And AI is also used for health monitoring systems to provide real-time information and alerts and to the clinicians in case of there's any emergency. And also AI is now used for predictive models, which is very important. This helps to predict a current disease for the patient or their current state of health, and they can also forecast a possible treatment for the patient. And it has been used for public health intervention. It can be used for prevention, lifestyle, and dietary management, and also is being used by clinicians for clinical decision support. And lastly, as I said previously in the previous slide, it is used for self-management for the patient. And AI has also helped for patient engagement using educational strategies. So the findings from the research also showed the based on these areas I just showed now, which of these AI is mostly used more. And the result shows that AI is used mostly for developing predictive models using machine learning, different machine learning techniques, whereby AI is used to predict when treatment is to be carried out and to also monitor the state of the uh, diabetes management. And lastly, AI is less used for health monitoring system. And this is because there is already different application that has been used already to address this issue for health monitoring systems. So AI in this domain is a little bit limited as compared to the other areas. For example, in clinical decision making, AI is used to provide expert knowledge to clinicians. So this is also an area that is also emerging. So the current application of AI in diabetes management. So AI is being applied, like I just mentioned, in several areas, and mostly one of the core areas that is emerging now is for diabetes prediction, mostly using machine learning. And that part is for lifestyle guidance to change or to nudge the patients on how they can change their diet to eat more nutritional or more healthy meal. And it's also help for insulin injection, mostly for patients with type 1 diabetes, for blood sugar monitoring, mostly for patients with type 2 diabetes. So for self-management, for patients to manage their own diabetes, and for complication monitoring, to monitor complication if there's any. And this is done mostly by the clinicians or the personal doctor of the patient. So AI actually uses data from different sources, as seen from the slide. So there are so many sources whereby AI collect data from. So many of these actually comes, for example, from the genomics of the patient, mostly from the lab, from clinical trials, also from imaging, and mainly most 50% actually comes from the medical records of the patient, and also the devices which they use, like the glucometer or the pressure devices. And also most data is also gotten from the mobile app and other sensors. So the sensors is like the medical devices used by the patient. And also the AI also use data set from the health, the current health diet of the patient, and also the physical activities. So using this data set, the AI model or AI algorithms are able to provide screening and prevention, diagnostics and prognosis, and treatment and management. So currently, there are different applications available out there for screening and prevention. So they help to address this issue, like for example, remote monitoring and AI-driven behavioral modification. And they also for prognosis and diagnostics, we have the early detection, we have patient support and education, and then for treatment and management, we have clinical system support, we have treatment optimization and population health management, and also BDT management. So there are several applications in this area where AI is being used based on data set gotten from different sources, and this helps patients with diabetes for them either to for treatment and management. It also helps the clinicians for prognosis and diagnosis, and it also helps also for early screening and also to further plan for prevention. So as seen from this slide, AI is also used for diabetes management. And when AI is developed as a tool, most of the existing tools actually have different modules. And one of the popular module is the food intakes that helps to check the nutritional intake of the patient. And then we have the physical activities that takes data on how the patients carry out physical activities. Do they go for example, exercise, and how long this exercise is being carried out, for example, walking. And it also measures their glucomia, measures like the sugar level in the blood, and also insulin dosage and the weights and actually pressure measures. So there are other models which AI is also carrying out, which AI get data from and is used to provide information for the patients and also for the clinicians. And AI also use data like demographic data and also the physiological data. So, for example, the age of the patient, their gender, their weight, their height. And this is also used with the BMI data, and this is used to provide self-management strategies for the patients. So this shows an example of an AI tool that is already developed. So for here, you can see that it shows the blood sugar. This now try to show the blood sugar pattern for the patient. You can also check this to show the blood pressure of the patient and also the weight progression based on the regimen or the intervention that the patient is currently on. And this shows the, for example, the meal the patient is currently on, like, for example, this is the information about before the launch and after launch, and this information is being used by the model to carry out some prediction. For example, this is prediction on blood sugar trends, and this can be used also by the clinicians to recommend or to advise the patient on how the treatment is going. And this also shows more prediction that is being carried out by AI based on the data that is being inputted by the patients, mostly data from their meal, from their exercise, maybe from their sleep, from other factors that may influence their intervention. So in AI for diabetes management, so what's the way forward? So currently there are so many research in this area, as I've said, and one of these emerging area is the use of wearables like IoT devices, Internet of Things, and how this can generate data, like the glucometer, like the biomarker, and also even the pressure meter, how this can generate data set that can be used by the patient. And this is also an example of a glucometer that is used to data from the patient on the current blood sugar level, and this can be used by the machine learning algorithm or from the AI-based model. And also we have other areas which is also being investigated. For example, personalized diets and lifestyle, and AI-powered kind of treatment. But in using AI for all this, there are also some challenges or barriers that is being face the use of this technology. So one of them is technological integration. So how do we integrate AI-driven systems or AI-driven models with existing or legacy systems already used by the health practitioners? So this is one of the challenges that is being addressed. So another is the development and resource cost. So the cost that is needed to develop these AI systems and resources. So these AI systems incur a lot of cost in development of the models. And also, there is issues on how to achieve open, reliable data sources for validation. For example, you need to be sure that the data you have is trustworthy and it has good quality. So, how do we ensure this? So, this is also another issue that is being investigated. So, we have issues of scalability, how to scale this for a wider population use when AI tools are being used. Maybe for a smaller population, it may be able to work in a you have a good performance, but when you include it to a larger population, what will happen? And how does it affect the existing clinical workflow integration? Because clinicians and the medical practitioners already have a way on how they treat patients with type 2 diabetes. So when you bring in AI, how does this affect or how does it impact this treatment? And similar to the development and resource costs, we also have the implementation and maintenance costs. How do you maintain these models over time? How do you get the data set? Is it going to be open data set or is it something that you have to commercialize and who is going to cover up this cost? So this may be extra burden for the practitioner or for the health care sector. And then there are also issues on regulatory concerns as has to do with privacy and data security of the patients, and also how to avoid generalization of data. Most of the AI models use generalized data, which brings about bias. So how do we have a less generalized data that is more inclusive and equitable? This is one of the issues that we have to address when implementing or using or deploying AI for diabetes management. So one of the recommendations we have for adopting AI for diabetes management is, first of all, we have to gather large amount of patient data. So we have to get a lot of data for the particular demographic where this AI tool is to be implemented. For example, if you want to develop a tool for a patient, for maybe a older person or elderly people, we have to get a data that is individualized just for them alone. And this is to be used for the AI model, not the data from the general population, because the data is going to be biased. And then we have to establish an in-depth crossover between the professional knowledges. So there must be a integration of knowledge gathered from the AI physicians and also for the AI technologists. So the AI technologists should not work in isolation. They have to work with the physicians to gather expert knowledge. And then there should be continuous updates and enlarge the existing knowledge base. So any data that's been gotten or any knowledge or best practice, this needs to be updated with time or occasionally. So this is very important. And then we have to perform standardized random control studies. So there's need for clinical trials, clinical studies to be carried out in using AI. And lastly, we have to involve both the clinicians and patients. So when we develop this system should be developed with the patient in mind. So it should be based on a user-centered development. So the patient should be engaged and be involved from the beginning of the development, from the beginning, not when the tool is being developed or after development, the patients are being engaged. So the patient should be engaged from the start before the project starts. Before the AI models are developed, the patients should be engaged. We need to know the patients, the requirements and their needs. So this should be captured when developing this model, and this will help to optimize the effectiveness of the AI tool since it's going to be tailor fit for the particular patient. So the future landscape of diabetes research is currently is more aligned to the diabetes prevention, diabetes care management, and lastly, diabetes research. And this is for type 1 and type 2 diabetes. So the current area of research is mostly in these three main areas. So some researchers are mostly based on diabetes research, for example, try to achieve data interoperability, open data. How do you achieve this? Like ethics, data security. So most researchers are based on this, while some are mostly based on diabetes prevention, for example, screening, health literacy, lifestyle change, and others are mostly based on diabetes care and management. For example, how to empower the patient and how to carry out better quality of life and psychological well-being. And AI is being used in line with other natural language processing or machine learning, for example, deep learning, and with the use of big data that is gotten from different sources, for example, from variables like the glucometer, from sensor, from smartwatches, and also from social media. And this data is used by these models. So in conclusion, healthcare providers are now they are exploring how to achieve cost-effective ways of providing high-quality healthcare for these diabetes patients, and there is the need to explore the use of AI because it has been proven that AI can be one of these effective strategies or effective tools that will help healthcare providers to have a cost-effective way of providing high-quality diabetes care. So AI actually can also help to estimate the risks of diabetes, and if there are also any associated complication, AI can help to achieve this. And AI can also help to provide personalized care for management of type 2 diabetes or type 1 diabetes. And lastly, there is a promise that the use of AI in diabetes management is has great potential, although it is faced with several challenges or several barriers, which I explained previously. So there is need to explore these opportunities and also how we can effectively and ethically and equitably apply AI for diabetes management to provide an inclusive care that is actually different from the classical approach. So this is most of the references I was used to prepare this presentation, and this is the end. Yeah, thank you very much. Thank you.
Okay, welcome. So now we are going to talk briefly about the applications of the Internet of Things in diabetes and other chronic diseases. This is an introductory lecture because this is a very fast evolving field, but we hope you find it interesting. So, of course, the first question that comes to mind in this context is what exactly is the Internet of Things? What are we talking about? Well, sort of the official definition is the Internet of Things is a network of physical devices and objects embedded with sensors and software that allows them to exchange data with each other and to be monitored and controlled remotely. So we are talking about gadgetry and devices and like physical things that have the ability to communicate with each other and to help people take decisions. Sometimes they can be autonomous. More often than not, they involve some kind of interaction with the user. So we in medicine are pretty familiar with many of them. Maybe we're not aware that they're part of the Internet of Things umbrella, but say we all use body temperature sensors. We have all used pulse oximeters, some of them remotely connected, um, automated BP measurement devices, sphygmomanometers, accelerometers we use quite frequently, airflow sensors, ECG sensors, EMG sensors, um, skin temperature and skin response sensors. So we use these technologies on a daily basis. But what is new about the IoT framework is that we want to try to connect them either among them or with a centralized repository that we use later for decision making. Now, what is the place of the IoT in health? Of course, there are many potential applications, but so far, most of them have been concentrated in the following areas: ambient assisted living, so remote health monitoring, mostly for older patients or very young patients, chronic disease management in general, and elderly care, which is associated with the first. So it has a lot of room to expand, but in general, these are the areas where it has found most applications. Of course, then in fitness programs as well. Now, the Internet of Things is not just this series of devices and sensors and their communication, but it has layers. So there is a first layer in which you have the perception of all the stimuli and the translation of that into informatics data or into basically files of information. There's a processing layer or middleware where this is filtered or created or somehow cleaned. And then there is an application layer in which usually individuals, but in the future probably artificial intelligence algorithms, use all this clean information or integrated information to make decisions and then impact the initial user of the technology. So if we want to look at some successful examples of the IoT for the chronic care of patients, one of the fields where it has been the most successful is hypertension. And even though there are several devices, this is the one I wanted to share today because it's really advanced or recently being validated, and it's a heart guide. So it's this little watch that will measure with a very considerable accuracy your blood pressure and heart rate. It doesn't have many more functionalities, but those two things it does very well. Now, when you compare the wrist blood pressure measurement with this little guy versus the ambulatory blood pressure measurement using the standard equipment, um, the average is really quite similar, especially for the systolic blood pressure. And the concordance is in the vicinity of 50 to 80%. But in general, the kind of information that is provided, it's equally useful. So these kind of devices have more and more penetrated society. Uh, and a little or a really interesting feature of them is that because you have to measure blood pressure in a given position of the arm to make sure that you're recording well, the actual blood pressure, you need to have it in a given position. So the device has a built-in accelerometer, which is able to detect the angle at which you're bending your arm, and based on that, the height of your arm, and based on that, it's able to beep or vibrate when you are in the right position, and then and only then you should look at the record and take that as the actual measurement. But it does so on its own. You don't have to calibrate it or tell it when it is in the right position. It will know for you. So that's really quite useful. Also, in the field of cardiology, IoT has also been used to monitor arrhythmias, particularly atrial fibrillation. So, this is a huge study of over half a million people who use the Fitbit accelerometer. So, this is a watch device or a wrist device that is basically an accelerometer. It's used in sleep medicine and in fitness medicine, but here it was used for the detection of atrial fibrillation. So what was new about this research in this paper is that they used the same old data, but they processed it using a new algorithm. So the raw data from the photoplasmography was used, and it was coded to be taken as an FA episode when at least the abnormal rhythm was recorded by 30 consecutive minutes. And when they applied this algorithm, what they found was that out of those who got reported as having a potential FA event using the Fitbit, about a third of them actually had confirmed AF with an ECG patch. So it is not, it is highly sensitive but not very specific, uh, with a positive predictive value of 98%. So as an initial screening measure can be extremely useful. It may not be still uh, a diagnostic device, but for screening of FA, it definitely has uh, quite a bit of potential. Now, in the realm of cardiac rehabilitation, sensors are like extremely useful. So this is a formal comparison of IoT home-based cardiac rehabilitation versus center-based rehabilitation. So when you think about cardiac rehabilitation, you think about the patient going to a specialized center where they have exercise professionals and cardiologists and nutritionists and a whole team devoted to their rehabilitation. However, it has come to the attention of researchers that you might do something similar and definitely quite less expensive and probably more convenient by combining information from different sensors and teaching the patient how to use that information to adjust his own, say, exercise program or nutrition program. And that's what they called IoT home-based cardiac rehabilitation. So when was a systematic review, but when the change in the LVEF is compared for the IoT-based rehabilitation versus center-based rehabilitation, they actually did better with the home-based, IoT-based program. Not a lot better, but somewhat better and significantly better. The same was found for the 6-minute walk distance. Again, not a huge difference, but in favor of the IoT solution. And the same for peak oxygen intake, about 2.2 milliliter per minute per kilogram. And all of these differences were statistically significant. They are not of immense clinical significance, but it suggests that IoT based rehabilitation can get to be at least as good as center based rehabilitation. Now, for COPD monitoring, here I want to bring to the field this little guy. This device is called the Sylvie. It really is a device to detect the amount of air that is trapped inside your lungs, inside your alveoli. It was developed by this colleague and friend of mine, Dr. Maria Artunduaga. She has a company now that manufactures this device, and she's going through all the regulatory processes to try to launch it as a product, hopefully by 2026. It is chest wearable. It uses acoustic resonance to assess lung function. And then it uses AI-based algorithms to identify changes in lung air volume, and it is proven to be very useful for the diagnosis and/or follow-up of COPD patients. So this is again a very interesting use of the Internet of Things. In neurology, IoT has saw a lot of application, particularly in epilepsy. There are a number of wrist accelerometers that have been kind of tweaked into seizure detection. So it is a usual accelerometer, but it has a special built-in algorithms that detect the kind of movements, the kind of patterns that are generated before an actual seizure. So they can be used for opportune and early seizure detection, and they can prevent accidents and many undesirable situations for patients with epilepsy. In Parkinson's disease, there are many applications, but one of the most interesting is you can do the usual movement test, but then have this gyro sensor, this gyroscope, placed in the patient's finger. And even if a clinician sees the movement as seeing normal or only slightly altered, the built-in algorithm detects subtle differences in the way patterns that the human eye cannot see, in the way the patient is performing the movements, and it's able to earlier and better detect Parkinson's or Parkinson's progression. Now, in diabetes in particular, um, there's a lot of space for IoT. You can have movement sensors, smartwatches, chest strap sensors, pulse sensors, blood pressure sensors, CGM devices, of course, data visualization solutions, and you can connect all of them to either your smartphone or to some other kind of connected device. So it is a field in which IoT has a great deal of promise. Um, Totally not completely fulfilled, but definitely making big improvements. So, how about the flow of information? All this information can be sensitive, and also it shouldn't be taken lightly. You need to perform a formal, in-depth analysis of all of the provided information in order to make wiser and better decisions. So you have all this information from the sensors. It has to go through a series of protocols to the integrating layers. Then it should go to the cloud. There should be some kind of pre-processing, classification, and then using the results, they should be relayed to decision makers, either doctors, healthcare experts, or the patient himself. So this is kind of the general framework for IoT in diabetes, but of course there can be many variations according to the particular application. Now, the importance of connectivity. These data have to be transmitted in a secure and safe way. Uh, and that's why there are many protocols, internationally standardized protocols to transmit data from sensors in the patient to the receiver or cell phone, from there to the cloud, and from there. to the decision maker, and the way this is relayed or transmitted has to be made uh, secure, safe, fast, and reliable, and as much as possible, not susceptible to hacking. Well, and in the field of diabetes, what would be the holy grail of the Internet of Things? Probably non-invasive glucose monitors. So something that you can use to measure your blood glucose without even having to place a sensor permanently or for a few days. Something that you can use without never getting into your body and that can monitor your glucose. So there are many solutions that promise this, but I want to bring in some of them. One of them is a Canadian device called the Scanbo. You place your hands like this, and it'll give you a very accurate estimation of your glucose levels and of your blood pressure. This iPhone watch, I think, is a British development. It looks more like a smartwatch, and it's based on a different technology, but it will also connect wirelessly and transmit your glucose levels in an almost continuous fashion. And then you have this is a German device. It's called Diamond Tech, and it has several models. This is Model D. It is very reliable. I think it is based in spectroscopy, which has been used successfully for chemical analysis of tissues in other areas, like neurology. You can input other kind of data, um, and they're all really advanced. They promise to be coming to clinical use over the next few years. Now, what are the challenges of IoT in health, which are very relevant to diabetes as well? They must be cost effective because if you're going to develop all this gadgetry and all these devices, it's because they're going to, in the long term, be cost effective. There needs to be some data validation and persistence. You need the data to be there, accessible. And if you need to access data from your patients 3 years ago, it should still be there somewhere. You need some real-time analytics, so the speed of the relaying all this information should be acceptable. They have or they must have a low power consumption because it turns out uh, the reliability and the usability of these devices depends very much on how often you have to charge them. So ideally, you should have a very low power consumption. They should be continuous, and you have to work with patients to have them wear them all the time. The hardware should integrate seamlessly because you will have different companies, factories, brands, models, and ideally, most of them should be able to communicate with each other without a lot of trouble. You have to guarantee data privacy and security because this information can be quite sensitive. You have challenges regarding to data storage. When you have millions and millions of patients producing millions of data points all the time and only increasing, then the ability to store all this information it becomes a challenge. And also, patient expectations must be realistic. This kind of solution is for fine tuning, improving diabetes management, but it will never replace just a general medical approach to disease diagnosis and treatment. And with that, I want to thank you for your attention, and I look forward to your questions. Thank you very much.
Hello, everyone. Thank you for participating in this event. In this talk, I will talk about some common terms and definitions related to the applications of artificial intelligence for the management of non-communicable diseases. And we will focus on the next four elements. First, we will talk about the current state of artificial intelligence technologies. Then we will briefly comment on the unmet needs in non-communicable diseases control and the possible solutions that are provided by artificial intelligence. Then we will discuss the ethical, legal, and social implications of using artificial intelligence in clinical activities. And finally, we will summarize the presentation and present some future directions of this field. I will start talking about the history and general overview of artificial intelligence. And in this image, we can see a picture of the original Star Trek. And there is an interesting fact. The story of Star Trek is set in the year 2263. So this is 200 years ahead of the current times that we are living. And this was the cell phone that was used by Captain Kirk. And by the time that this show was released in the 60s, it was considered that this was quite revolutionary but we can see how this cell phone cannot be compared to the capabilities of current technologies and the cell phones and smartphones that we use nowadays. And this brings me to the idea of digital revolutions. For people that are above 30 years old, we have experienced several changes in the way that we run our lives and we communicate with other people. First, internet was popularized in the 90s. Then smartphones became popular in the early years of this century. After the smartphones came, the social networks create an important impact on the way that we communicate our ideas and our experiences with our communities. So you can imagine how different is the communication nowadays than the way that people communicated more than 30 years ago. So what is artificial intelligence? Artificial intelligence is when we have computational entities that mimic human intelligence capabilities or characteristics. And there are several elements that are important to bring artificial intelligence to life or to our daily life. The first is hardware. We need specialized computers with a lot of programming power or processing power in order to process multiple different inputs and outputs simultaneously. The first transistor was created in 1947 by Bell Labs in the United States. And this device was kind of this size. It was about 15 centimeters tall and about 10 centimeters wide, and it was only one transistor. However, if you know the technology that is behind your cell phones have one or multiple processors, and these processors can have billions of transistors. So imagine that we move from having one transistor of this size to have billions of transistors in one small chip that is located within our cell phones or computers. The other important element for artificial intelligence is that we want to run specialized algorithms or software in order to use the capabilities of the hardware, the transistors, but that would allow us to process a lot of information, a lot of data. In the past, if we think on processes like medical attention, a lot of the information was stored in paper, in a physical resource. So it was very difficult to access that information because a person would have to go and check out the physical records of a patient in order to collect some particular pieces of data. However, nowadays, a lot of the information that is collected in clinical services or in our daily life, for example, in our cell phones, is digital. And when information is digitalized, it allows it to be processed by computers or by these kind of processors that are used in artificial intelligence. So then we have two very important elements: the hardware capabilities and a lot of digital data that is available for being processed in these computers. So where is this technology going? This is an image from 1997, and this image shows where the final game between Kasparov and Deep Blue. Deep Blue was a supercomputer that was trained to play chess, and this was the final game of the competition that in which Kasparov was defeated. So this was the first time that a computer defeated a human in a task that we consider very complex, like playing chess. Something like this happened 10 years later when the best Go player, a game that is even more complicated, was also defeated by a computer. And Deep Blue, that was this special computer that was trained to play chess, it was the precursor of Watson. Watson was a supercomputer from IBM, and IBM created it so that the computer could process a lot of information that would be useful to help us solve big challenges that are faced by humans. One of the challenges, for example, was supposed to be the cancer. So the idea was that we could use the potential or capabilities of Deep Blue in order to find a cure for cancer. And although the expectations were really high, and Watson was able to do a lot of different tasks, finally, the expectations didn't live up to the reality. However, a lot of people started to talk about artificial intelligence, not by the system that I presented, but because of generative AI. And a lot of people started to use ChatGPT in the year 2022 or 2023. This system is relatively new. In the past, artificial intelligence was reserved for people that were experts in programming, because in order to use the tools that were known related to artificial intelligence, it was very important to know how to code, how to program a computer. So a lot of times, the people that did these tasks were software engineers. However, ChatGPT did something very good, and it was that it opened the artificial intelligence to the masses, to the communities, because it created a front end and a screen or a service in which people could easily interact in natural language with the computer. And that was the big jump or the big advancement related to ChatGPT. And ChatGPT is one of the different styles or characteristics or services models related to artificial intelligence. ChatGPT is part of the category of LLMs, large language models, that are specialized artificial intelligence models that run under natural language processing. And on the right, you have this image of technology adoption. A lot of you probably use Netflix. And when Netflix was launched, it took 3.5 years in order to get 1 million users, 1 million customers. But as the technologies advance and people get more familiar with the different technologies, it was easier to capture or to get a large audience for the different tools. So for example, for Facebook, it only took 10 months to achieve 1 million users. But here you can see how ChatGPT got to 1 million users just in 5 days. There are several fields for artificial intelligence. We have expert systems that are systems that are normally trained to follow a decision tree, although they can operate under the other different paradigms. But overall, they just follow some rules, basic rules. So for example, if the patient has high blood pressure, then I create the diagnosis of hypertension. Then if the patient is hypertension, I can classify it in some particular categories depending on the blood pressure that was found. And depending on the category, I can select a particular treatment for that particular patient. We also know about automatization systems. You can think on an automatic car, like a Tesla, that is a self-driving car. It means that these particular kind of vehicles do not need a driver in order to operate. But you don't need to go too far to think on automatization for a Tesla. There are multiple devices that we use in our daily lives. For example, Roomba, which is this vacuum cleaner that can scan the surroundings in an apartment or a house and automatically can go and clean the different rake that can go into the floor. This brings us to robotics, but there are also two very important fields of artificial intelligence. Machine learning, that have several subdivisions, for example, deep learning, reinforced learning, supervised and unsupervised learning. And finally, we have natural language processing that, as I mentioned before, is the foundation for the large language models such as ChatGPT. Now, I'm going to discuss some of the unmet needs in non-communicable diseases. I will not talk a lot about non-communicable diseases because before Carlos and Anthony presented a summary of this, the importance of studying these diseases and controlling them in order to provide a better health status for the communities. So now I'm going to talk about the unmet needs and possible solutions. I'm going to focus only on some of them. So for example, early detection or early diagnosis, limited remote diagnostic and services, complex multimorbidity in patients, poor treatment adherence, interrupted monitoring, lack of personalized diagnosis, the importance of addressing mental health issues in patients suffering from non-communicable diseases, and finally, holistic rehabilitation. Here, I'm starting with the number one, which is the early detection. It is very hard to address non-communicable diseases because in a lot of times, these are silent diseases. A patient can have high blood pressure and they feel nothing. They would only discover that they have high blood pressure when they go to the doctor and their blood pressure is measured, and the doctor finds that the blood pressure is relatively high or high. So diagnosing non-communicable diseases is an important challenge. However, deploying deep learning An example of this could be the convolutional neural networks. It is possible to analyze medical images or other kind of information coming from the patients to come up with early disease markers. And in this case, we will be able to create to provide an early diagnosis for conditions that can come in the future. And this can be applied in multiple settings. There are examples of artificial intelligence models used to study EKGs, but there are also AI models to support, for example, the development or the deployment of echocardiograms, MRI, CTs, coronary angiography. This is an example for cardiovascular disease, but in all the different communicable diseases, there are examples of tools that are supported by artificial intelligence that help us to diagnose these different diseases earlier. There are examples. There is one study in which some researchers compare the performance of some artificial intelligence models with the performance of cardiologists. And they gave both the artificial intelligence models or the doctors a set of EKGs that they have to read and create a diagnosis. Many of these EKGs look normal and actually were described as normal by the cardiologists. However, when the researchers asked both the cardiologist and the AI model what was the probability that some of these patients would develop heart failure, for the normal EKGs, the cardiologist would say, well, the probability is quite low because the EKG is normal. There are no signs of left ventricular hypertrophy or something like that. In order to predict that this patient is going to develop a heart failure. However, in exactly the same EKGs, the artificial intelligence model predicted 30% of the patients that end up developing heart failure in the next 2 years. So there was something in the EKG that could not be seen by the doctors, even specialized doctors, but that was detected by the artificial intelligence model and helped the model to predict that these people were going to develop complications, in this case, heart failure. So, and this brings us to one of the challenges of using artificial intelligence, and is that a lot of times the inside of the model is not well known. Well, the engineers can program the neural network, but what is going on inside of the neural network that is inside of the processing capabilities of the artificial intelligence model sometimes cannot be described. That's why a lot of people call this area like a black box, that we don't know exactly what is going on, but we know that the output is reliable. So there are also some teams that are trying to explain what is going on inside of these neural networks in order to help us to identify which are the features that are being taken by the artificial intelligence model to create more accurate predictions. If we are able to determine some of these variables, maybe we can also improve our own performance. Number 2 is remote diagnostics, and is the use of artificial intelligence to close the gap of attention services that are provided for people, for example, in a city versus people that are living in rural areas. And using artificial intelligence can help us to develop better telemedicine platforms and mobile health applications that can help us to interpret the diagnostic images or to analyze, for example, lab tests or information that is present on an electronic health record to provide better recommendations for the patient. And here I am presenting an example of an intervention that was created in India by the Public Health Foundation of India. Several people participated in this project, and one of them is Dr. Doraira Prabhakaran, that was a guest in one of our research events at the Universidad de los Andes in 2018. They developed this system, which is Empower Heart, which is an M-Health system. And what did they do? So basically, they created a system in which a community health worker could go and visit people in rural areas far from a hospital, and then they would collect information from the patient, and even they were able to do some lab tests at the site of in which the patients were living. And then this information was collected in a mobile phone, and then the information was sent via the internet to the hospital. In the hospital, there were doctors that were reading the information that was being captured far away, and they would provide recommendations for diagnosis, treatment, and they could, for example, provide some prescriptions that could be delivered again back to the smartphone used by the community health worker, and in that way the community health worker could give them the right and appropriate information to the patient. And here they show the impact of this program. So using this system in the province of Himachal Pradesh, they found that after 18 months, they were able to find a sustained drop in systolic blood pressure, diastolic blood pressure, and a drop in the glucose levels in the patients that receive care supported by this mobile health intervention. Here, we can also see how artificial intelligence can help us to manage multimorbidity, because we understand that patients can have multiple diseases, and in order to diagnose and to treat the diseases, there could be multiple approaches. So artificial intelligence model can integrate data from various sources, including the electronic health records, lab results, imaging, to support decision systems that could help us to coordinate better care plans for the patients. And here there is only one example. Using artificial intelligence can help us to estimate which is the right test based on the characteristics of a patient and we want to diagnose a particular condition. And then the artificial intelligence can also help us actually to be better at executing some of these tests. In this case, this image is showing the uses of artificial intelligence for medical images related to cardiovascular disease. And artificial intelligence embedded in the software that is controlling some of these machines can help us to develop better protocols that are specific for the patient, and they can help us to shorten the time in which the patient, for example, is inside of an MRI scan. If you have ever had an MRI, you know that you have to stay for at least, 30 minutes inside the machine. However, maybe we are able to run some of these models, we might be able to save some of that time, and maybe some of these tests will be run in half the time with exactly the same quality of the results. So each one of these boxes are different applications of artificial intelligence in different stages of the diagnostics or therapy or treatment protocols in which the patients are participating. And some people are concerned about the cost, because obviously creating and deploying some of these models could be expensive. However, what is actually known is that yes, they could be expensive, but they can save a lot of money in the long run. And this is a position statement from the American Heart Association, in which they show how it could be possible to create value through artificial intelligence when we use these models to support some of the daily tasks that occur in a hospital. In this case, they mentioned that what is valuable for the patient or for the society could be different from what is valuable for the clinician or for people in financing offices within the hospitals. But still, artificial intelligence can help us to reduce costs and increase the quality of the services that we are providing for the patient in the long term. And importantly, we can reduce complications, which many times are very expensive. The fourth point that I will touch on is the importance of artificial intelligence to manage adherence to the different therapies. For chronic diseases, it's very common to find that a lot of the patients have poor adherence to the treatments. And this could be explained by different reasons. Sometimes patients do not understand well the goals of the treatment, the mechanisms of the treatment, for example, which specific steps should they take in order to take, for example, some pills, or sometimes they are reluctant to actually follow the instructions from the physicians for multiple different reasons. But implementing artificial intelligence in elements like mobile apps or chatbots can help us to provide personalized care or reminders for the patient, and it could even be useful to increase motivation in the patients to follow the instructions for the patients. And in this particular image, we are showing an example of a group of patients that suffered a stroke and then were assigned to different interventions. In one of the interventions, the patients have daily monitoring through this application, which is ACure. And patients that use the application have a much better adherence to the anticoagulant medication that the patients were prescribed. For the fifth point, I will talk about continuous monitoring and interrupted surveillance. Because traditionally, a lot of the diagnostic processes or the process of measuring some variables in the patients occurred at the hospital. So normally a patient, if they want to undergo an EKG, they would have to go to a healthcare center in order to have the EKG. If they needed an spirometry, they have to go to a healthcare center with spirometry devices to be monitored. However, nowadays, as Carlos presented, there are multiple wearables that allow us to collect a lot of clinical information or clinically relevant information from different biological variables from the patients, and they do not have to be at the hospital. They could be at their homes, they could be at their works, and we can do a continuous monitoring of some of these variables. And having that data could help us to guide both diagnostic, therapeutic, or follow-up processes for these patients. And in this image, I just show that it is important to consider the use of some other technologies. So using artificial intelligence is important, but using systems like blockchain can help us to adequately store the data that is being collected and manage the confidentiality and privacy of this information and avoid, for example, technology issues, because if you only store the information in a server and for some reason this server is without power, then you will not be able to access the information. So using services like blockchain can help us to have this information safe in different places and actually to monitor that the information is preserved in the right way. Because if somebody tries to change the information in one computer, the other computers will resist to this particular change. I mean this in the context of non-legal actions. So when people are trying to adulterate the information. So using blockchain can help us to increase the security and confidentiality of the data, and can increase the access and the availability of the data for research or for clinical purposes. Now, we can also talk about the uses of artificial intelligence for precise and personalized diagnosis. As we know, all of us are different. We have different genes, we have different exposures to variables in the environment, and artificial intelligence can help us to categorize the importance of these different variables in our phenotypes and for the selection of some therapeutic strategies that are customized for the needs of each patient. There are multiple models that can be used. This is only one example in which you can use graph neural networks for precision medicine. And these use specialized mathematical models, and you can feed data from different variables. For example, here we have drugs, we have information about diseases, we have the phenotypes that we find in the patients, we have different exposures to different variables in the environment, variations, for example, in the structure of the body, genes, pathways, and the system can analyze this complex information that could be present in different formats and help us to better see the relationships between the different variables. And this cannot only be useful, or this is not only useful for addressing some biological variables for research, but we can also use it to improve the efficiency of some clinical decisions. One important need in the hospitals is to define which patients have to be admitted to the hospital after they visit the ER, because being admitted to the hospital could be an expensive process, because staying in the hospital will increase in many costs. So you want to admit the patient that really needs to be admitted, and maybe you can provide ambulatory care for people that can be managed at home. And also, the number of beds is a limited resource in a hospital. So knowing how to better manage this particular resource is very useful for people in different healthcare institutions. And using some other kind of graph neural networks, you can monitor different variables from the patients to increase the efficiency, for example, of triage in ER services, but also for patients that could be admitted. Now, we cannot forget the importance of mental health for these patients because living with a chronic disease can impose some challenges for the communities, for the patient, and for the relatives that are helping to take care of the patient. So we can use different tools from AI to support mental health, both in the patients, the communities, or the caretakers. And this is an example of one of these systems. Here I'm using ChatGPT 4.0, and I wanted to show you how easy it could be to create a very simple application that could be useful for the patients. So here I asked the system, please provide 5 examples of tasks that you could accomplish with just one prompt. So I don't want to use multiple prompts. I just want to create a very quick example with just one prompt to support the management of NCDs. And immediately the system starts to respond. I can, for example, generate a personalized patient care guide in seconds. That is something that I can do. It can build a chatbot for real-time NCD education, analyze a large NCD dataset, design a social media campaign for NCD awareness, or create a clinical decision support tool for physicians. So these were the 5 options that the system gave me. So I said, please run number 2. And then the system started to do this. So it said, okay, so I'm going to create a chatbot to provide education in NCDs. And this is a very simple version of the chatbot. The system is creating the code for a programming language that is Python. And then you can go and copy the code and insert it in a different application in which you can actually program. And this application is here. So this is Google Colab. So I took the code that was created by ChatGPT with just one prompt, and then I came to Google Colab and copied the code. I copied the code, then I run the code, clicking on the play arrow. It takes about 5 to 10 seconds. And then it created the chatbot. It is running. Is ready. So now this is a very simple chatbot. Remember that this is only one prompt. And then it says, ask me anything about diabetes, hypertension, heart disease, cancer, or obesity. So I ask how to control my diabetes, and it provided a simple question. Then I provided a second question that is, what would be different if I also had high blood pressure? This is the question that I'm typing here. And this is the response. In this case, the chat is asking for additional details because remember, this was one single prompt. It was only one example of the capabilities of the system. So the code that was created was actually relatively small and relatively simple. But if you were working with this for real, seriously, you could maybe interact with the system for 1 or 2 hours, feed the system with a lot of information. Depending on the model that you are using, you can even put an entire book. If you are using something like Google Gemini, you can have 2 million tokens. That means that you can feed a lot of information into the system. You could even have like an entire book of diabetes and load the book into the system, and then the system will read information with great precision and provide very specific responses for the people that is using the chatbot. It is important still to be careful, and some safeguards or guardrails have to be implemented in the system to avoid that information that is not relevant or useful for the patients would be released by the system. But this is very, very useful. You also have to teach patients and even healthcare workers that these systems can fail or that they are not always accurate. In my particular experience, because I am a pharmacologist, a doctor, but also a pharmacologist, and I teach pharmacology, when I use ChatGPT or any of these systems for questions related to pharmacology, I would say that maybe 70% of the answers are correct, but maybe 30% of the answers are not correct, are wrong. But I can notice that because I am an expert in the field. If one of my students were using ChatGPT, they probably will not notice the mistakes because they are not experts in these particular topics. So it is important to recognize the limitations of using these systems and being careful with using the output that is provided by the different models. So it is important to use critical judgment to analyze the results. And please, let's not forget about social determinants. Remember that socioeconomic, cultural, and environmental factors impact the outcomes related to non-communicable diseases. However, data that is coming from a socioeconomic study is different from the information that is connected from a cultural study. For example, it could be qualitative, whereas the economic studies could provide maybe quantitative results. And also environmental factors could be multiple. We can talk about the characteristics of water, the air that we are breathing, the food that we are consuming, and all of these are elements, variables, are impacting the outcomes related to non-communicable diseases. And although this is complex data, for us, it is not as complex for the artificial intelligence systems. So we can use artificial intelligence to do big data analytics, collecting these different kind of variables, and information is coming from different sources to provide better recommendations for the patient. And this is an example of another study in India in which they use machine learning to study social determinants of health related to chronic illnesses. And the authors found that before they took a model with a particular data set, and they found that the information was not balanced. That sometimes when we were trying to look for some specific variables related to NCDs, some of these variables were absent in most of the patients and present in only a small fraction of the sample that was studied. So then they have to do some adjustments into the data in order to get more balance in some of these variables. And the conclusion is that it's very important to understand the differences in the quality of the data or the variability of the data that is feeding these artificial intelligence models in order to get recommendations that are more useful for our patients or populations. Now, as Dr. Mendivil said before, there are hundreds or thousands of applications available to address non-communicable diseases. This is a website from the FDA. Let me run it again. So you can go to the FDA, and this is the database of medical applications that have been approved by the FDA for the management of different conditions. In this particular example, I went to the database. I was checking for which were the apps related to cardiovascular care, and there were more than 50 applications that have been approved by the FDA. Surprisingly, if you go to this database, there are only 2 applications that have been approved by the FDA for the management or care of diabetes. Now, which are the challenges of using generative AI or artificial intelligence in general in healthcare? First, the AI models are trained on diverse global data. And many of these models have been trained on data, especially coming from developed countries. And not necessarily they are trained on data from developing countries. So a recommendation from these models that is appropriate for Europe or the United States may not necessarily be appropriate or useful for a developing country in the global south. And again, this is an example. So I asked the system to create an image about an educational campaign for migraine. And this is the image that the system created. This is using DALI that is embedded within ChatGPT 4.0. Okay? And then immediately after this image was created, I said, well, now please show me an image displaying an educational campaign for migraine, but in Colombia. And this is the image that is created. So immediately the system shows that people maybe in a health-related educational campaign in a country like Colombia can only occur, for example, in a rural area. People are very different, shares, technology. So this means that the information that the system has about Colombia is different and is very biased compared to the information that the system has about some other places in the world. It is also important to take into account that the artificial intelligence technologies are not equally accessible for everybody in the world. And I am a believer that if we use artificial intelligence correctly, we can help to close the gap in development between developed and developing countries. However, if we don't use artificial intelligence, the gap will be even wider. And this is what is represented in this image here. So this is kind of the present situation, and this is what is going to happen when some communities will be very well developed because they are using artificial intelligence for different applications, not only for healthcare, but in different economic fields. But the people that are not using them, they will just be left behind. And it is important to remember that education, legislation, and the cultural adoption of artificial intelligence lag behind the actual development of these models. And this is what is shown here. The regulations are like a tortoise. However, the development and the models are like a rabbit, and they are moving really, really fast. And in many countries, the regulation for the adoption of artificial intelligence is non-existent, or is very weak, or is not as precise. The European Union have worked a lot on developing policies and regulations for the implementation of AI in different fields in their communities. And in 2023, they released the European Union Artificial Intelligence Act. And this figure is trying to show if the models that were available by that time, end of 2023, comply with the requirements that were in this particular regulation. So the field dots show what was known or what was actually released or opened by the model, or the elements that in which the model were complying with the requirements from the governments, and the white dots were all of those fields in which the models were not complying with the requirements. Now, to end, I will finish with this slide. And just to remember you that it's very important to collaborate and to scale and to implement these models in our communities. First, to provide better care for the patients, and second, because otherwise our communities will be left behind and the actual outcomes of conditions such as the non-communicable diseases will be even worse. And artificial intelligence will help us to integrate data from different systems. Eventually, we will be able to have genomics, epigenomics, proteomics, metabolomics data from patients. But we will also have data from exposomics, the exposure to different environmental variables. We will have the data coming from the wearables. And we could integrate that data, for example, to select better drugs that could be prescribed to the patients, or to develop better medications that are personalized for kinds of populations, and through this process, we will be able to increase the efficacy of the therapies, decreasing the amount of side effects. We can also develop more efficient trials, and we may be able to move faster from the development of some medications or therapies to the actual deployment and implementation of these therapies in the communities. So with this, I want to thank you for your attention, and I will be happy to answer any questions that you may have. You can share maybe the questions through our social media for the medical school, or via our email. So you can write to arpena@uniandes.edu.co, and I will be happy to answer the questions that may come after this presentation. Thank you very much.